Good evening. Welcome to tonight's MyCP webinar series on ableism in healthcare. My name is Paul Gross. I'll be your host. This webinar series, we largely cover our research that's going on in progress with the community and get input. Tonight's a special opportunity. I had heard about the presentations that Dr. Fuentes had done on this topic, and Dr. Bjornson said this would be great to do a webinar with, and based on the reactions to us broadcasting this one, that is spot on. So I'm really excited to have Dr. Fuentes talk about this topic. So I typically do an introduction to the CP Research Network so you understand a little bit more about what we do and your opportunities to engage with us, and then I will turn it over to Dr. Fuentes. So I want to talk a little bit about the starting of the CP Research Network. There was a seminal meeting of the National Institutes of Health in 2014, late in 2014, that was entitled The State of the Science and Treatment in CP. And that was a very unique meeting because at the end, the organizers stood up and said, we heard 5 or 6 key topics and we wanted to assign to people that were there to join a task force to move it forward. And that was really, really effective for an NIH meeting. And so what the things that came out of that were, if I can get my mouse to advance, were the need to establish a national registry to track how common the condition was, but really to accelerate research, to do more comparative effectiveness research. So this is a specific type of research that compares interventions to see which one is better in a real world setting. So this picture of ovals or circles in green and yellow is from Dr. Iona Novak's paper called it's called the stoplights paper, but or the traffic lights paper, but it's about which interventions have strong evidence or moderate evidence for their success. And you can see there are so many interventions for targeting the same types of outcomes that there's a real need to compare things and see which things are most effective. Slides just went away. Another thing was the study of adults. It's estimated that there are about 1 million people with CP in the United States. And if you just look up at a bell curve of age, if this is correct, that's roughly 200,000 kids with CP and 800,000 adults. And at the time we looked at the amount of research, and there was virtually no research going on in adults back in 2014 at the time of this meeting. The need to develop a research agenda for basic and translational science, so not just clinical research that gets done in sort of a hospital setting, but like what are the mechanisms or the causes, and how can you take things that you learn about causes and translate that into interventions or changes. To bring more young investigators into the field was a really important thing. When we looked around the room of that 2014 meeting, there was a lot of gray hair and really a need to kind of grow the field. And then there was a real need to create closer connections between patients, families, and investigators. And these things ended up becoming the mission of the CP Research Network. So we were founded in 2015 to optimize the lifelong health and wellness of people with CP and their families through high quality research, education, and community programming. This picture here is when 45 of us split almost exactly evenly between clinicians and members of the community got together to discuss the priorities in research that resulted in our publication that drives our work. So we really have sort of 4 pillars of the CP Research Network. We have our research and quality efforts, where we get together twice annually with investigators, including community investigators, to discuss the projects that are going or things that need to be started. We have our educational efforts. We've just added a new toolkit to this list called the Dystonia and CP Toolkit. We've got our health and well-being program, and then all of our efforts like these webinars to engage the community. So our vision is that by engaging a very large number of stakeholders, both community members and people that care for people with CP, and a large number of health systems in a learning health network, which is a specific thing that uses the data from treatment of people to improve the treatment of those people. So a learning health network for CP, that we could collectively improve the care of people with CP for issues that people cared about most, the ones they identified in that meeting in Chicago in 2017 that resulted in a paper in 2018. And that by allowing the community to share their lived experience and then measure aspects of the healthcare process for addressing those, we'd be able to create a platform for continuous improvement of health about the health that matters to community members. So if you move forward from 2015 when we were founded, on the education front, we launched the CP Toolkit. We've served over 6,000 people. We went on to launch well-being guides and CP Toolkit translations, and now the Dystonia Toolkit. We're working on an adult toolkit. So we've got a lot of work getting into sort of really focused on the community educational materials. We launched MyCP to do personalization of all the rich content we have on our website. And then things like these monthly webinars that we conduct. On the research front, as I said, we were really trying to address many of the things that were talked about in that meeting. We actually launched a clinical registry, i.e. a registry that collects information from people as they come into a clinic visit or a hospital visit, which is now over 12,000 patients. It was launched in March of 2016. And we launched a community registry in March of 2019, which is intended to gather additional information from people's lived experience outside of a hospital setting. And that's got just around 3,000 people in it. Research CP is the outcome of that meeting that you saw the picture for. We published that in 2018, and that really guides our work. And then we went on to get some significant funding in translational research, with our genetics study from NIH, and we later partnered with the largest private funder of research in the United States, CP Alliance Research Foundation. We do quality improvement as well as research. Quality improvement is just another way to change outcomes. And so we've got actually 6 of these projects now across the network, but hip surveillance is a great example where surveilling hips is really important from the time that kids are born to the time they achieve skeletal maturity. So improving the outcomes around surveilling hips is critical. We're also academically focused. We try to publish the results of our work. We've had 16 publications to date, over 45 academic presentations, and we've got many manuscripts based on our work that are in various stages of writing, submission, revision, that will be coming out over the next year. And then now that our registry is so large, we can use it as a basis of data to do secondary analyses, which is to say, you've got all this data, what can you learn from it? And so we're very actively doing secondary analyses and using the data that we've generated to strengthen grant opportunities with public funders. And then on the wellness front, we tried a number of things, but we really partnered with the National Center for Health, Physical Activity, and Disability to create the Mentor program. If you haven't heard about this, go to our website and search for Mentor. It's a tremendous free program that we offer in partnership with NCPAD. And we're working on developing a similar type of program for pediatrics. So I want to give you a little bit of an idea about what's in a registry. So I'm going to give you 2 data points from our clinical registry for starters. One is gross motor function classification system. This is a 5-level scale of how people move around through the community. 1 through 3 are ambulators, 4 and 5 are wheelchair users. 3s use a level of assistance. And you kind of can see the distribution of our thousands of patients in the registry. This is back from when we had about 10,000 in the registry. And then if you look to the right, you see we've got some age bands here, and you can see about 25, 26% of the registry are adults. And so that gives us a very large body of of people to draw from to conduct studies. The community registry, on the other hand, is gathered based on people filling out online surveys. And so if you look at those two data points, you see a different distribution of GMFCS, which is, you see a much stronger lean towards people that are ambulatory. And then from an age perspective, you see it leans way towards adults. A much larger percentage of the community registry are adults, and that's because adults are out there actively advocating and contributing data to see the field advance. So we are a 35 site or hospital system network. The green pins represent sites that are actively collecting data into the registry. The blue pins are pins that are sites that are working, I'm sorry, blue pins are candidate sites. Yellow pins are sites that are working on preparing the registry technology. The red pin is a site that's still working on that compliance aspect. And again, the blue pins are all ones that have signed up. They've said, they put their hand up and said, we're interested, but it takes a while to get onboarded. And then the green circles are sites that are lifespan centers. And that's where all the adults that are in our registry are coming from. So we really exist to stimulate the research ecosystem as sort of our biggest investment that we do with our nonprofit dollars. And our strategy is one to let 1,000 flowers bloom. So we started out by sending that patient-centered research agenda, as opposed to going with what investigators want to study. It's really, research is much more impactful when it's driven by the community. We went on to build infrastructure, registries, this network, our data coordinating center, to make it so that investigators would have a better chance of getting public funding. And then we try to balance between both this generation of evidence, which is this, new learning, versus just improving care, which is this quality improvement mechanism that I described a little bit earlier. And then we use the registry, this underlying database, to monitor both the implementation of those care improvements and outcomes overall. So the way we conduct our research is we have a process, a standard operating procedure by which ideas can be generated. That's that concepts on the left side, the wide part of the funnel. They get reviewed. If they get approved, they move on to try to find funding, or they get internally funded. If they get funding, they get executed, and then we look at the data, we write about it, and then we publish it, and then we try to take those findings and push it back into the way medical care is conducted. So I'm going to run an animation, and it's going to take you from our founding, and you're going to just see an arrow going across the top of each year, and then bubbles in these three colors that you see there about the types of studies we're conducting. It's going to take about 10, 15 seconds to just show you the progress of letting 1,000 flowers bloom over the last bunch of years. So as you can see, we're very busy, and it's not quite 1,000 flowers, but we've got a lot of activity going on across broad range of ages and both quality initiatives and research initiatives. So what I would say in conclusion about our work is we really are, creating a unique value proposition for research and quality. We're creating a platform that it can continue. And part of that is when we did our meeting in 2017, it was just so clear that all the answers people wanted, we needed to study much longer than the standard 5-year outcome. And we have a platform now to study outcomes over longer than 5 years, that we can look at long-term impacts. And it does implement a learning health system where the information from care is being used to improve care. And we're now extending it into studies of things that may not even result in CP, but other comorbidities. So injuries like hypoxic ischemic encephalopathy, large percentage of those kids end up with CP, but we're also going to enable the study of that whole early NICU course. So that's what we do. I'm really excited, though, to turn it over to Dr. Molly Fuentes, who is an assistant professor of rehabilitation medicine at the University of Washington and practices at Seattle Children's as a pediatric physiatrist. And she has both lived experience with tonight's topic, as well as a particular interest in health disparities. And so with that, I am going to turn it over to Dr. Fuentes.
Well, while we're getting started, I'll just do a bit of introduction to myself as well. So you kind of got to hear my academic introduction. My experience with disability is really through my siblings, and actually now my father as well. And so my oldest brother has intellectual disability and epilepsy. And so I grew up, like one of my earliest memories is sitting with my grandmother in the car outside of what I now know is his early developmental preschool. But I grew up on the reservation, and so he had to go to a developmental preschool that was an hour and a half away from the reservation, and so that's why my grandmother would drive us, was so that my parents could work, and so he could still access services. And then some of my other early memories are being very, very envious of his getting to take seizure medicines. I really wanted to take medicines too, and got in very much trouble when I tried to take some of David's medicines. And so that was kind of my earliest experience with disability or with healthcare systems. And then when I was 15, my sister, who was 3 at the time, was in a car crash along with my parents, and she sustained a complete spinal cord injury. So she is paralyzed from the neck down. She has a trach and breathes through a ventilator. And so that was kind of my most kind of sentinel experience with disability, was my sister, becoming, she had been typically developing and then had this very severe motor disability, lots of engagement with the healthcare systems, pretty much every medical specialty that there is, she ended up having to have that discipline. So neurosurgery, infectious disease, pulmonary, orthopedics, rehabilitation medicine, she had a separate unrelated kidney injury, so she even had a nephrologist. And part of that experience with my sister is what led me to becoming a pediatric rehab medicine doctor. And so I had wanted to be a doctor before that, but I probably would have been a family medicine physician, because that's what I had exposure to through the Indian Health Service growing up on the reservation. And I'll just kind of get started with going through what the slides are. But I was 15, a freshman in high school, and my sister was injured. And when she went through inpatient rehabilitation, and then we were discharged to our home environment, the reservation, it was really hard to get private duty nurses to want to accept the assignment there. And so my parents actually ended up deciding to move off the reservation to the town, the nearby town, because it was easier to get home nurses, and it was easier to, we were that much closer to the little community access hospital. And so all of these are some of my lived experiences that I bring to all of my clinical encounters. And then this, to add some more context about this talk in particular, this talk actually originated as an invited presentation to some specialty boards. So these are the specialty boards, are the boards that give specialty certification to physicians. And so it was the American Board of Physical Medicine and Rehabilitation, the American Board of General Surgery, and then the anesthesia, the board of anesthesiologists that wanted to talk on ableism. And so Amy Houtrow, who's a pediatric physiatrist at Pitt, and I collaborated on this presentation, and I'll tell you when the slides that are being shared are Dr. Houtrow's work. And so this is what we'll be doing today. And next slide, please, Christy. So just some definitions. So, the Americans with Disabilities Act defines that disability is a physical or mental impairment that substantially limits at least one major life activity. And then the Center for Disease Control, the CDC, defines disability as the condition of body or mind that makes it more difficult for the person to do certain activities and interact with the world around them. So next slide, please. And really what's important is that disability impacts all of us. And so this is, these are some graphics from the CDC sharing about, how over a quarter of adults in the United States have some type of disability. And so this is really something that everybody should care about. All physicians, all of healthcare should care about it. If you look in the upper right-hand corner, the highest prevalence of disability type is the mobility or motor impairments, then cognitive, and so on and so forth. And then there are disparities or inequities in disability between groups. So as you would expect, 40% of adults 65 and older, so our elders, have a disability. 1 in 4 women have a disability. And then about 40%, 2 in 5 non-Hispanic American Indian Alaska Native people or indigenous people have a disability. And so, and then if you look at the graphic on the left, you can see that the percentage of people living with disabilities is highest in the South. And so there are, cultural inequities, geographic inequities, many inequities around disability. Next slide, please. Which brings us to the definition of ableism. So Professor Fiona Kumari Campbell, who's a professor of disability and ableism studies at the University of Dundee, defined ableism as a network of beliefs, processes, and practices that produces a particular kind of self and body, or the corporeal standard, that is projected as the perfect, species-typical, and therefore essential and fully human. Then disability then is cast as a diminished state of being human. Next slide. Dr. Heidi Jans defined ableism as social devaluation on account of disability. Go ahead and click. I'll just say click. How about that, Christy? And then click again. There we go. These, and then, sorry, go back one. Sorry. And then Rebecca Coakley, who's a disability activist, was in a conversation with Ibram X. Kendi on his podcast, Be Anti-Racist. And this podcast title was Ableism and Racism, Roots of the Same Tree. And she said that, these ableist ideas are deeply rooted in anti-Blackness and eugenics, colonialism, and capitalism. And you don't have to be disabled to experience ableism. It's really grounded in the notion of who is valuable and worthy based on a person's appearance and or their ability to produce, reproduce, excel, and or behave. And ableism, has an impact. When you look at disability and health, the adults living with disability are much more likely than adults living without disabilities to have obesity, to smoke cigarettes, to have heart disease, to have diabetes. Click. And they have significant more barriers to accessing healthcare services. So, a third of adults with disabilities don't have a usual healthcare provider or a primary care provider. A third have an unmet healthcare need because of cost in the past year. And, a quarter didn't have a routine wellness checkup in the past year. So there's health consequences. These next slides are from a study that Dr. Hautrow did with people living with disability, looking at their access to healthcare services. And so, people with disabilities did not have equitable access to healthcare and related services in their study. First off, health-related information is not readily available. So this participant talked about not really having anybody to turn to. So there wasn't information that they knew about pregnancy and having a disability. Click, please. Participants talked about how healthcare providers lack disability expertise, that not enough time is spent on patients' needs, and how there are long wait times for appointments. This participant said, "I feel very frustrated, and it would take so long to get in with these doctors. I'd wait months and months just to be blown off, and I would lose hope. I would feel frustrated, and it sucked, really." Next. Participants talked about how providers do not respect disabled people, that it's very rare to not have a doctor that's condescending. Next. And with the healthcare providers lacking disability expertise, this participant felt like I have to do so much of the legwork just trying to figure out my symptoms and what might be going on with me or what kind of test I might need. A patient shouldn't have to do all that by themselves. That should be the doctor's work. Next. That healthcare is too costly. So this participant, there's been situations where I just couldn't go to an appointment or get a test done that a doctor ordered because I couldn't afford it. I just straight up couldn't, and I had to skip it, and that's never good. It sucked being in that kind of situation. Next slide. Talking about insurance processes, creating barriers to needed care, and that the insurance doesn't always cover it. This participant talking about you're up against conglomerate insurance companies now rather than individual service providers, and that makes life much harder. Click. And I just want to comment that denying insurance coverage based off of pre-existing conditions is exceptionally ableist. And for those for people who remember what healthcare was like before the Affordable Care Act, which made denying coverage based on pre-existing conditions against the law. It is not a situation that we want to go back to. And also the lifetime caps on care that existed before the Affordable Care Act was covered is also ableist. My family personally, we were very lucky that my mom was a teacher, and so she belonged to the teachers union. And so they had the purchasing power to create, to buy group plans that, after my sister blew through her first, $1 million care cap, the Oregon Education Alliance switched insurance companies so that my sister could, not just so my sister, but one of the effects was my sister could restart at zero and blow through another cap. And then, so we were protected that way because of the power of the education union. And for people who, if my mom hadn't been a teacher, it would have been a much different situation. So I will always believe that denying coverage on pre-existing conditions and lifetime spending caps for healthcare coverage is incredibly ableist. Next slide. The healthcare environments are not accessible. So for this participant, they talked about trying to get their annual pelvic exam or women's health exam, that because it's such a production, getting on the table, somebody to hold your legs, can't lay down anymore without having breathing equipment. So I have to bring that in, plug that in, set it up, and just dreading the next time I have to do that. When I read this quote or heard this quote, it really reminded me of an experience that my sister shared, that she's never had a pelvic exam because they were insisting in the small town that we live in that it be done in the operating room. And her health insurance actually wouldn't cover the operating room costs. And the hospital was insisting that an anesthesiologist needed to be present, even though no anesthesia was being delivered because of my sister's trach and vent. And so she made the decision just to not have a pelvic exam and said, well, if I get, if I'm having problems, it's just what'll happen. And, I'll deal with the consequences of not having that screener. But my mom fought so many battles trying to get the hospital to either not make it be in the operating room, not have an anesthesiologist, or not charge the operating room fees, and never came to a resolution for that. And so the inaccessible environments and inaccessible health tables and exam tables are such an issue. Another story from my personal patient experience. So when I'm in Alaska, I'm in a hospital-based clinic, but one of the patients who is a power chair user shared a story about how the only pediatric ophthalmology clinic in the state of Alaska is on the second floor of a building that has a really rickety elevator. And so this patient, who is about 11 at the time, like a tween, was drove into the elevator with his power chair, and then his mom got on, and the elevator wouldn't go up. They it was saying there was too much weight. And so they really needed to get his eyes checked. So what they did is his mom pushed the button and ran up the stairs as fast as she could, hoping to get there before the elevator got there with her son. And then he drove his power chair out. But he said it was so scary, being in the elevator by himself, because what if it broke? And so just the inaccessible healthcare environments, also very ableist. Next slide, please. And then transportation to healthcare appointments being unavailable or unreliable. So, the days when the transportation provider just did not come, or if you went to your appointment, they leave you and it might be 4 or 5 hours before they get you and you're stuck. Next slide. So what this slide is showing, it's an able-bodied privilege checklist. So I feel like, a lot of you have probably seen privilege checklists. We're not going to go over each of these points. The website that this came from is there. But the things that really struck me when I was reading this were, easily being able to find housing that is accessible to me, not being called upon to speak as the token person for people of their mobility level. Growing up from childhood will not feel that my body is inferior or undesirable and that it should be fixed. When speaking with medical professionals, can expect them to understand how my body works, to answer my questions, and to respect my decisions. And then number 21 was so powerful to me, that all people like me are seen as living lives that are worth living. Next. And I think this able-bodied privilege highlights many aspects of privilege around mobility, but I felt like it didn't really cover as much of the privilege with cognition or communication impairments, which I feel like I'm also attuned to because of what I witnessed my brother going through as he grew up. Next slide. So now I'm just going to share some anecdotes of experiences that I've had within healthcare. And so this first story is, I was in a care conference with the father of a 7-month-old infant who was 2 weeks after a significant anoxic brain injury. And in the care conference, there were, doctors from the pediatric intensive care unit, there were lung doctors, there were palliative care providers, there were members from the neurology team. And I think I will always remember what this father said. Click. He said, "How long can we wait before it's too late to..." He kind of mimed pulling a plug and made a zipping sound. "If she's going to always need a diaper, can't eat, and can't walk, that's not a quality life." Then I had another patient, the mom of a 10-year-old with CP and severe hip pain. I actually saw this child in Alaska. The primary care provider of one of my other patients had found my cell phone number and reached out because this child was having such severe pain from their hip dislocation. And so the mom, was recounting the visit that she had recently had with a surgeon and was requesting a referral for a second opinion, because the surgeon had told the mom that he said it didn't matter because my child wasn't going to walk anyway. He was just so dismissive of my child as a person. I would never let him operate on my child, knowing he said those things about him right to my face. And so they were referred to a different orthopedic surgeon. And then this last anecdote is actually my sister. So the day that my sister was injured, they had been life flighted back to the level 2 trauma center, and a neurologist at that hospital was threatening to petition the court to remove my sister from the ventilator, from life support, because my parents refused to withdraw care. And this neurologist felt like it was not going to be a quality life that my sister lived. And I also would would argue that, especially looking back, that there was probably a lot of racism involved. We lived on the reservation. My dad, who was the parent who was conscious and who made the decision to continue care, is my brown parents. My mom is white. And this, I think this neurologist thought that my parents and my family couldn't handle the care needs that my sister would have living with C1 tetraplegia. But because of that, my parents have never trusted neurologists since then, and have, when my sister has been hospitalized before, they've insisted that she always have a family member with her because they're so afraid that somebody in the healthcare system would make the decision that her life wasn't worth living and would take her off support. So next slide. Ibram Kendi from the same podcast shared that it's pretty apparent to me that one cannot be anti-racist while still being ableist. And I'm going to kind of skip through these next things because there's actually been a lot of writing and a lot of discourse about how to make academic medicine less anti-racist, but there hasn't been similar work on how to make it's coming there. It's in the pathway, but it's not as robust of a literature for how to make academic medicine and medicine anti-ableist. So go ahead and let's skip several slides here. We'll keep clicking through. I think the ICF is the International Classification of Functioning and Disability and Health is a great tool for structural competency and thinking about experiences from a holistic lens. But what I really like is that the environmental factors and the personal factors, go ahead and click, are really what's, and one more click, what we now talk about is the social determinants of health. And so go ahead and click once more. And the social determinants of health are really rooted in these root causes of health and these underlying systems of dominant culture and narratives, of which ableism is one. And so next slide. So ableism, this study was looking at physicians' perception of people with disability and their healthcare. Click. And it looked at over 700 physicians from 7 different specialties. And 82% of these physicians reported that people with disability have worse quality of life than people without disability. Only 40% were very confident that they could provide the same quality of care to people with disabilities, with non-white physicians more likely to feel very confident. Nearly half did not strongly welcome people with disabilities into their practices, though female physicians, shorter serving physicians, or physicians who are closer to their training, and those practicing in academic settings had higher odds of strong welcome. So this is just showing the pervasiveness of ableism within healthcare providers. This quality of life piece, I think, is so important to always push back on, because when studies have been done of people with disability or disabling conditions, their rating of their well-being and health is often very discordant with their objective health status. It's much higher. People rate their quality of life much higher. And I saw that with my sister. She told us, we were sitting around the table with my grandparents when they were still alive, and they were talking about their health. And my sister was like, well, when I'm your guys' age, when I'm 85, I would, I'd love to still be living at 85 as long as I'm still healthy. And so in her mind, she is still healthy, even though, you show somebody from the healthcare system, they would see her chair, they would see her ventilator, they would see her trach, they would see the pressure sores, they would see the scoliosis, and think that that is not a healthy person. But in her mind and in her experience, she was. And then click. And then I think it's all, and this is something as a rehab doctor I'm always thinking about, is, are the interventions that we are offering ableist? And I think of this father of a patient who asked me when we were discussing a referral to orthopedic surgery, what if we do this surgery and when he gets older, he thinks we didn't love him enough to accept him the way he is? which still sticks with me to this day. And I have some more slides. I can make them available just to the CPRN website, but I also want to respect everybody's time. And we could also just pause here. This slide is really just to talk about how the medical literature really recognizes that racism, not race, is the risk factor that makes people from different racial and cultural backgrounds experience worse health outcomes. And that's it's exposure to racism and structural inequities that has biologic consequences. And ableism similarly is a social construct. And so we really need to include ableism when we're addressing health inequities for people with disabilities.
Should I stop it there, Molly?
Yeah, why don't we stop it there? The last slides were really about kind of suggestions that were more for the boards of rehab medicine and general surgery and whatnot. Let's stop sharing, and I can join my phone.
Yeah, I saw your phones there. That was great. And if you can share your slides with me, Molly, if you're fine with that, people have requested them.
Yes.
Amber Gorman put a great question into the chat, which is, what can we all do to help educate medical professionals better about ableism? I'm curious, I'm sure you've gotten that question before, and I'd love to hear your answer, your thoughts on that. This gets to my self-advocacy question that I asked you prior to the talk.
Hopefully my face is showing up now too.
Yes, it is.
We can see you.
Welcome.
Yeah, we can see you now.
So I think one of the things for educating healthcare professionals is so much of healthcare happens within the walls of a hospital, and people don't want to put intention in other people's minds, but I think that healthcare providers get so focused on what's happening within the walls of the hospital and seeing the person who might be coming to them when they're sick, when they have a lung infection, and that's not how they really live. That's not them at baseline. And so bringing in those personal photos, showing what the person or the child does on a regular basis when they're feeling well, what we're trying to get them back to and out of the hospital, is a reminder of kind of like helping healthcare providers recognize the richness of life for people with disability outside of that hospital bed. I think that I would love it if disability studies or a course on disability justice was a required part of the pre-medical school curriculum, so that people came into medical school with a better understanding of disability justice and kind of be ready to push back against the Western medical framework, which is quite ableist in the way it tries to approach or fix things kind of with that typical health standard. So I think and then within medical school, and this is something that people don't have that much control over, I don't have control over it, and I'm in a medical school faculty, is having didactic curricula where there's a focus on disability. And so I think something that people can do is, if you're ever invited to speak to medical students or to speak to residents or trainees who are learning healthcare, to share your experience and to share your lived experience, like, say yes and do whatever you can to be there so you can share those experiences. I think that in education about disability should start well before undergrad or medical school. I think that, normalizing representation of people with disability in the media, spreading the word about inclusive media so that people watch it, so that they're reading Out of My Mind and watching it when it comes out on Disney Plus, to show that this is media that people care about and that they want to see. Best Foot Forward on Apple TV. There's so many opportunities out there to support better representation of people with disability in, in cultural activities. We need to increase the population of medical students with disabilities as well. And then kind of part of that involves supporting medical students with disabilities as they move on to training. One of the studies that's on a slide that I didn't have time to share is talking about how few of the medical residents who would benefit from accommodations requested them, because they've reported a fear of stigma or bias if they requested an accommodation for their disability, which is not, like, it's just not okay. Like, if people feel that way, like there is something wrong in this house, the call is coming from inside the house, and we need to take action against that and make sure that our future physicians with disabilities and our physicians with disabilities are well supported. Responding to microaggressions around disability and ableism, I think, is really important. That said, I think as a person who has received the microaggression or who was microaggressed against, it can be really hard to decide whether you respond to that microaggression or not. There's a burden of response. And if you had to respond to everybody who was a microaggressor to you, it could be a really heavy burden. And so it's okay to not respond every time. And it's also
Dr.
really
Fuentes?
hard when there are power imbalances present. So like the patient, the patient whose surgeon made them feel like their son's life didn't matter. He was one of the few orthopedic surgeons in that state that could take care of the child. If they didn't have the means of traveling out of state, they might have been stuck with that surgeon. And so that mom might not have wanted to say anything back to that surgeon, because what if he like didn't take her child's case? What if he didn't take that good of care? And so responding to microaggressions, if you feel like it's safe for you and if it's something that you feel comfortable doing, and that can be even just saying like, I think I heard you say, having to wear a diaper is not a high quality of life. Is that right? Can you tell me more what you mean by X? What leads you to that conclusion? To try to make people reflect on what they're saying and how it's ableist.
Dr. Fuentes, I've got a couple people with hands up. There's a great discussion in the chat about more representation, but Susan Pacerno's had her hand up, and then Heather, Susan, if you want to unmute and ask your question, fire away. And I am aware we're coming right at the top of the hour. Just because we had a little technical challenge. Are you okay hanging out a little bit past 6, or if you need to wrap, that totally understand. Okay, go ahead, Susan.
I am fine.
Hi.
Great, thank you.
Thank you for taking my comment. I'm concerned about the fact that the American Academy of Cerebral Palsy and Developmental Medicine, they're always using the term children with cerebral palsy, and they've been told repeatedly, endlessly, that cerebral palsy is a lifelong disability, which they already know. I no longer can think it's an accident that they're using that term, because it's just been brought to their attention so many times. And then the other thing I wanted to say is I decided to see if ChatGPT was biased. So I went into ChatGPT 4.0 and I said, how many people have Parkinson's in America, and how many people have cerebral palsy in America, and how should research dollars be prioritized? And ChatGPT said there are more people with cerebral palsy in America than with Parkinson's, and therefore research dollars should go primarily to Parkinson's. And I said, ChatGPT, you isn't this contradictory? And it came back with, oh yes, that is an error. But the reason I said it was because people with Parkinson's are adults and people with cerebral palsy are children. And I said, ChatGPT, don't you know that cerebral palsy is a lifelong disability? And then it said, oh, why, yes, I suppose that's true. So maybe research dollars should go to CP. And I said, well, will you keep saying the wrong thing if anyone else asks this question? And it said, no, I'll be giving correct information now. But of course, who knows if that's true or not. But I thought it was both horrifying and hysterical. And thank you for your time and for coming tonight.
Thanks for sharing those little anecdotes. Interacting with ChatGPT very often produces entertaining results. Heather, go ahead.
I'm probably the only Canadian here. So we don't have an American, like a Disabilities Act like you do. And there's other concerning things going up in my country and things that I'm running into in the healthcare system here that I just want to kind of give a heads up, because this kind of discussion is sort of needing to happen ASAP, even as states in the US are debating, I think you call it assisted suicide. Here in Canada, we've had MAID, which is medical assistance in dying, for 8 years. And I'm not really bringing that up as a main point of discussion. It's just, as a person with a disability, they've taken it farther in the medical community here. And I've had 3 hospitalizations in 2 different provinces. And I've been asked 3 times to consider taking MAID because my life isn't worth living, or I don't have a good enough quality of life. And then when I tell them that's not their call, they tell me I'm being selfish. So this kind of discussion needs to happen ASAP, because it can go really bad really fast other ways. And that's all I wanted to say.
Gosh, Heather, I'm so sorry to hear that. That's horrible. Dr. Fuentes, do you want to comment? Or, I mean, I know that she's just making us aware.
I think that first off, thank you so much for sharing your experience and for advocating for yourself and letting them know that you are happy with your quality of life, or that you want to keep living. And I'm just, again, so sorry that that's been your experience. I think that there's studies that are out there, and first off, things shouldn't have to be in the literature or published studies to be worthwhile contributors to knowledge. Like, that's a very Western concept as well too. But that said, when you're working within the biomedical space, having like published literature to talk about can be helpful. And I'm thinking about there's studies like I referenced before that showed that discordance between kind of the objective health measures, your pediatric quality of life, or your quality of life score from your NIH promise measure, not really capturing the experience of disability or the richness of the quality of life that is experienced. I'm thinking of, there's a study that surveyed emergency room physicians and then rehab medicine physicians, thinking rating, and again, it shouldn't be the physician rating that matters, but rating quality of life for people with spinal cord injuries. And the rehab medicine physicians rated quality of life much higher. And so I think there's a lot of between specialty differences and differences in beliefs and attitudes as well. And so, finding your first off, self-advocating, but then finding your allies within your healthcare system who are going to stand up for you and to not let people get bullied into making decisions that aren't in their best interest. Because that's what it sounds like, that you're being extremely bullied by your healthcare system.
Okay, thank you. And that was just really hard to hear, Heather, and I'm sorry you've had that experience. And I second Dr. Fuentes' support for your strong. It is not their call. Kind of amazing. Arthur, you're up.
Hello, everyone. I am going to be bouncing up and down because I have a 16-week-old on my lap, and he is not happy if I'm not bouncing a little bit. So I have mild CP, and I have an accommodation agreement through work, and I am part of an inclusion network at work for people with disabilities, which is like an employee resource group. And I just realized during the course of this talk that, well, no, I've realized it before, but it came up again that there have been times when I had the thought of, do I deserve to be a parent if I need an accommodation agreement just to be able to do my job? And I work at a computer. I don't need to go into an office to do my job. I work from home now via that accommodation. And that's like, I realize how hard that is to hear from myself. And I also, in a recent conversation in that inclusion network, someone made the point that I work for Seattle Children's. We work at an organization that cares for disabled children, and we often forget that disabled children turn into disabled adults when we make it. Oh, sorry, I should stop there. You need some help. Anyway, I would love your thoughts on that.
Yeah. When you said inclusion network, I was wondering if you worked at Seattle Children's, because that term, but I feel like, and that privilege checklist, it's not one that I called out, but one of the things that was on there, it was number 16. People do not tell me that I should not have children. And so first off, I think that your child is so lucky to have you as a parent, because you're going to bring all of those wonderful experiences with you. I think that, and this kind of goes to, and I'm forgetting the first commenter's name, how the AACPDM keeps talking about children with CP. And we all need to think about, yes, that transition. And transition is not just the transition from pediatric healthcare to adult healthcare, but it's kind of launching into life and launching into independent life. If somebody needs support moving forward, like launching that family into that next phase of life. And one of the things that as a pediatric healthcare provider I try to think about is, how am I helping support that holistic transition? I know the schools have a role in that too, and kind of the transition to either secondary education, or for people who are in life skills classes, transition to that. But there's still so many gaps and places where people can fall through the cracks. And I would think that people who might not have qualified for IEP services in the schools wouldn't have support from the education system for making that jump. And so that kind of link between the healthcare and education and vocational sources, we probably are missing a lot of people. And as a kind of thought community, we need to not talk about just kids with CP, but also adults. And kind of going back to Rebecca Coakley's quote about how ableism is grounded in the notion of who's valuable and worthy based on a person's ability to produce, productive work is one of my least favorite constructs within rehab medicine. A lot of adult literature on the inpatient rehab side, at least for people after like traumatic brain injury or spinal cord injury or stroke, will talk about return to work as the kind of a primary outcome, a primary positive outcome. But it shouldn't all be about work either. People's value is not just on whether or not they hold down a job. And then also that saying, like the discrimination that people with disabilities who are in supported work environments experience with their super substandard minimum wage, or how it's, they're not entitled to the same minimum wage as everybody else, is astounding to me still as well. So lots of places, lots of opportunities for growth.
Yeah. Now that I don't have a crying infant with me, I remember my last point was really thinking about how deep the roots of ableism go, because to make any request for additional time and space from providers means we need to somehow convince them to buck the system that is trying to convince them to be more productive and more efficient. And somehow taking extra time is unproductive, is inefficient. And that is really like how deep this all goes.
Yeah. And thank you so much for calling that out. And I'm really happy that I practice in a space, in a field, and then in a space where there are fewer time pressures. Like, the standard rehab medicine clinic appointments at Seattle Children's Hospital are 45 minutes. And then actually in my Alaska clinic, I get an hour per patient, which still doesn't sound, it still isn't long enough all of the time. But then I think about like general pediatrician appointments that are 10 or 15 minutes long. And there's no way that provider could have a meaningful discourse or meaningful discussion of really almost anything. Like just the system, providers are really set up to fail in those systems, in addressing the things that really matter and understanding the things that matter to their patients. It's not decreasing the modified Ashworth score for spasticity isn't the outcome that might matter the most to our patients. What matters the most, will vary from person to person. And I'm thinking of, one of my patients in Alaska, where what mattered to them was being able to take their child onto the tundra with them so that they could pick berries together as a family. They didn't really care how it happened, and it's really that different focus, that focus on participation rather than what the body function or the body structure is, that I feel like medicine and healthcare and the biomedical model of disability really misses the mark by not bringing in what matters to people, which is really part of just the way knowledge is created. There's a whole set of philosophy within medicine on epistemic injustice and how knowledge and decision making happens, and whose knowledge is counting when healthcare decisions are being made. And it shouldn't be the physician's knowledge or experiences, it should be the patient's, but it's usually the other way around.
So Dr. Fuentes, let me, just to be respectful of your time and everyone's time. So there are 2 more questions that have been queued up. Nobody else queued up a question for a bit. Do you feel like you have time to take those 2, or do you need to wrap? I'm totally.
I can take the other 2 questions.
Okay, so I'm just, so everybody knows, I'm going to close it after those 2. Charles Franz, you're up next.
So it's a pleasure to meet you, Dr. Fuentes. I wanted to ask you if you could elaborate a little bit on what you think would benefit medical students who are hoping to pursue a career in medicine where they can advocate for people with disabilities.
Yeah, so I think for medical students, so presuming that kind of pre-medical student is still in the undergraduate environment, like seeking out classes through if there's a disability studies program at at the university, like even if it's just an introductory course to disability studies, I think that would be super helpful, and also like show a lot of initiative to the medical school admissions committee that, you know, you want to do something about that. If you're not still in the undergraduate level, you know, just seeking out other experiences, whether it's through, you know, through volunteering, you know, going to the disability studies organizations in the institutions to learn, and just showing those, you know, reading whatever you can about it. There's also some great like documentaries that are out there too, like Crip Camp, and learning about Judy Heumann and all those, you know, kind of the activists that came well before us, just to build that baseline knowledge and that context of what the experience has been.
Great, thanks. Amber, you're up. Last question of the night.
Hi, thank you so much. I think you really hit it on the head when you said it's about valuing each person and for who they are and what's important to them in life. I was just curious on your slide where it's I think it was the poll where I think it was 40% of white or Caucasian physicians thought they were doing well or whatever. Why do you think that is? Because I just found that interesting, because I've had varying experiences with different physicians of all different cultures, and I can say it hasn't been the Caucasian, I'll say male Caucasian physicians who have done the best job. It's actually been Caucasian females have always done a good job, and then the physicians from other cultures like India and other places have actually done fairly well when it came to certain things. So of both, you know, of both. So I was just curious about that.
Yeah, so I can rephrase what the study was. And so that was when they surveyed the 700 physicians from the different specialties. 40% of the respondents said that they felt very confident that they would be able to provide the same quality of care to people with disabilities. So meaning that 60% weren't confident that they could provide the same quality of care. But the non-white physicians were more likely to feel confident in their ability to provide high quality care to people with disabilities. And then the second piece was the strongly welcoming people with disabilities into their practice. Female physicians, younger physicians, and those practicing in academic settings had a higher odds or higher likelihood that they would strongly welcome people with disabilities into their practices. And so I think that that first bit, the corollary to the 40% feeling very confident, meaning that the 60% weren't confident that they could provide the same quality of care, really is reflecting the lack of exposure to people with disabilities in the medical school curriculum and the training curriculum, which is, again, mind-boggling to me, since disability crosses every medical specialty. You cannot, you know, regardless of what specialty you choose, you're going to work with people with disabilities. And so we should be providing better training so that people will feel very confident that they can provide the same quality of care.
Well, it's like I told somebody just recently, I said, you know, the disability culture is the only culture out of every single culture that includes every ethnicity, every sexual orientation, everything. We are the rainbow of the cultures.
Yes.
And I said, you might belong to it from the very beginning, like me, having CP, and I also happen to be an OT, so I am in the medical part of it too. But I said, everybody will belong either at the beginning, the middle, or the end. I said, you just never know, because I'm always telling people, make sure your house is accessible, whichever house you buy, whether you're 20, you're 30, you're 40, or you're 70. As an OT, I tell them that.
Yeah.
And people look at me like, well, I can walk up the stairs. Yeah, but tomorrow you might not be able to. You know, so, but it's the only culture everybody's going to belong to at some point in their life. And people are like just in awe when they hear like that, like a light, but like that, like that's just, it's just like a light bulb went on, but like, wow, I never thought of that, you know?
Yeah. And I think, thank you so much for bringing that up, the importance of like universal design and universal access, because it would make everything much better just from a physical space standpoint, which then would enable more people with disabilities to be in all of those different spaces, go to friends' houses, so that there's, you know, it's just a more inclusive space if there's universal design. I think that the inclusive knowledge is also really important, and I feel like that's where a lot of kind of the arrogance of knowledge, when one point of view is prioritized, or, you know, the hegemony of Western medical teaching, where biomedical experiences are prioritized, and, you know, randomized controlled trials are prioritized over qualitative studies. And then that leads people to just have big blinders on and not understanding kind of the fullness and the richness of the lived experience, and the limitations of, you know, certain biomedical approaches, which I think is hard for physicians. Sorry, I'm like dogging on my field. Hard for physicians to accept, you know, and because you go into medicine hoping to help and hoping to heal. And I think that the lived experience, recognizing the lived experience, helps people realize that healing is more than cure. Healing is more than, you know, removing a health condition. Healing is acceptance. Healing is inclusion. Healing is participation.
Yes, thank you so much.
Great. Dr. Fuentes, this has been great. Really appreciate all the anecdotes, all the research that you quoted, and sharing of your personal experiences. As you can tell, for at least for us, this is a very, you know, big and engaged group. I'm sure it'll go on to get viewed. These things get viewed hundreds and then eventually thousands of times afterwards. So thank you so much for your time. Thank you, everybody, for tuning in. Really appreciate it. Have a good evening.
Thank you all for sticking with me through the technical difficulties.
Yes, I appreciate that. Sorry for not asking for your slides in advance. I apologize, everyone. Thank you, everyone. Bye.
Thank you. Bye-bye.